Three, two, one. Please start, sir.
Yes, good morning to all and everyone. Again, today we have joined on this Sunday, that is the second Sunday of the month of December 2024, last Sunday of this year for our program. And we are with you with another edition of ICOG PG Clinic. We are grateful to Foxy President Dr. Jaideep Tank, Dr. Parul Kodawala, Chairperson ICOG, Vice Chair ICOG Dr. Sheila Mane, and Secretary of ICOG Dr. Sarita Balerao for giving us this opportunity to continue with ICOG PG program. This program is run every second Sunday of the month for the benefit of postgraduate students all over India. The program is structured in a way that we fulfill NMC guideline also and try to update and try to put focus on some of the topics or some of the area of interest for postgraduates so that they learn and they learn the technique also, they update their knowledge, and by this probably we are putting an effort to stimulate them to learn and read further about the subject. We are not targeting and we never had this objectives that we will be teaching you line by line. Our idea and our concept from the beginning is very much clear that we are here to give you an concept, an idea about a topic so that you can further read and you can identify the must know topic. Basically, we are focusing on must know topic that you should know as a postgraduate student as per our NMC guidelines. So, with this objective, I am also thankful to my colleague Dr. Hafizur Rahman and Professor Ashish Kumar Mukhopadhyay. They are always with us for PG Clinic, and all are making efforts so that a constructive program and a message is given to all the postgraduate. We try to have speakers and teachers from different parts of the country. We always have students from various medical college and institutions of different parts of the country and try to reach to different corners of the country so that at least wherever the resources are poor, at least this type of learning gives them an opportunity to update their information and try to have some insight into the subject. So with this objective, today we have planned our program. First, we will be having fetal skull and maternal pelvis demonstration by Dr. Ashish Kumar Mukhopadhyay. And today we will be discussing about and showing you the occipito-posterior position, mechanism, and principles of management. Then we will have case discussion, a very common problem, anemia. This case is very common for our day-to-day practice and very common in exam. But today we will focus mainly how to manage this case in third trimester and in labor. Basically, we will focus on when to give medical uh, tablets, when to give injectables, when to give blood transfusion, and what should be our obstetric point of view. And we have students from Tata Main Hospital, Jamshedpur, Dr. Vedika Patnaik and Dr. Monica Nautiyal. They will be presenting the case. And Dr. Maushmi Das Ghosh, the senior consultant from Tata Main Hospital, Jamshedpur, is the coordinator. We are thankful to Tata Main Hospital for joining us and allowing us to be a part of your institution in presentation. We have Dr. Ashish Mukhopadhyay, Dr. Kavita Singh from Gandhi Medical College, Jabalpur, She is the Dean of the Medical College also. Dr. Shakun Singh from LLRM Medical College, Meerut, and Dr. Jitesh Shah from SMIMR Medical College, Surat, as an expert for case discussion with the students. And in the end, we will be having the theme of learning the master technique, how to do it, and skill uh, learning, skill-based learning. So in this, we will be doing how to examine a case of uterine prolapse or pelvic organ prolapse, because it is a very tedious job. We sometimes fail to understand what to be examined and what are the steps. So that is, and it is a very detailed examination. So we thought that we should demonstrate how to do this. And Professor Niharika Dhiman from Maulana Azad Medical College, Delhi, will be giving us some tips and tricks of examination of a case of prolapse of the uterus. So this is our content today. And again, I am thankful to our President Foxy and Chairperson ICOG Dr. Parul Kodawala and Chairperson-elect Dr. Parag Biniwala, who has promised us to continue with this program in the next year also. Now I hand over this to Professor Ashish Kumar Mukhopadhyay to introduce the clinic and then continue with the presentation also. Sir, now everything is yours. We will not interfere in between. You please continue.
Namaskar, everyone. So, with kind regards to Professor Ashok Kumar, who is the main stimulus of this program. So the concept of this program is reaching far and wide our vast country with a simplicity in mind and exam orientation for the students. So that was the initial impetus that put us through. And with the three, Professor Ashok Kumar, myself, and Dr. Hafizur Rahman, I've been trying for last over 3 years, to spread the message of education, not only book teaching, but also the exam techniques, and which will also be useful in the future clinical life. So that is the motto. And as you heard, every second Sunday of every month, we are there for you. And remember, each of these programs is recorded, and they're in the ICOG website. So, my dear students, if you are for any reason cannot attend any particular class, go back to the website and find out the program. Everything is listed out there with the entire video. So with that, I thank profusely our Foxy President, our Secretary General, ICOG Chairperson, and ICOG Secretary for allowing us to continue this. And on this mission, we are together with all the Foxy and ICOG team, I can tell you that. And any sort of assistance or help necessary from the Foxy will be provided to you. So today we have got 3 sessions. One is the first session is the Master the Dummy Pelvis, which is very, very important, not only from the exam point of view, but also clinical point of view. You need to understand the mechanism basically. Then second theme is the case discussion, which is as per the NMC guidelines. And we have a very important case of anemia in pregnancy, this time third trimester of pregnancy particularly specified. And the third one is the developing the technique of how to examine a prolapse case in detail and record it in your exam sheet and your future recordings. So I will be the first one, the opening batsman. I'll be dealing with the occipito-posterior position. Now let us start this way, that occipito-posterior, I think, is an under-discussed topic in obstetrics. Why do I say so? Because occipito-posterior is roughly 10% of all vertex presentations we have occipito-posterior. Sometimes they are diagnosed, but most often they are not diagnosed. Now, what do we mean by occipito-posterior? I'll show you the pelvis and the fetus in the occipito-posterior position. But before that, we must learn what is normal. Manoj, could you put a focus on me so that people can see properly? So the normal position.
Sir, if you can like a little bit, you can.
Yeah. Is it visible now? The pelvis is visible now.
Yes, yes.
And you please, Mr. Manoj, please pin down Dr. Ashish so that he is only visible in the single view. Put it on the single view.
Yeah.
Yes, do it.
Yes.
So normal position for the fetus to have an uneventful labor is occiput anterior. You can see this is the occiput anterior. This is also occiput anterior, occiput anterior, occiput anterior, occiput anterior. This is called a normal position of the fetal head. But when the fetal head, that means the occiput, goes backwards to the back, we call this occipito-posterior position. If we take this head singly, then you'll be able to see this is the normal occiput anterior. This is the occiput. This one is occiput. Occiput is anterior, anterior, anterior. When it comes to back of the pelvis, that is, this is called occiput posterior, posterior, posterior. This is called a malposition. That means the position of the fetus is abnormal. That's why you call it a malposition. Now, as you know very well, that roughly 97% of the fetus is cephalic presentation in labor, roughly a few percentage this side, that side, and of which, and our 3% is breech, so rest other things are quite uncommon. But occipito-posterior as a malposition is quite common. 10% of all vertex. Vertex means this is the part of the head, that is the quadrangular part of the fetal head, which is here, bounded anteriorly by the bregma and the coronal sutures, posteriorly by the lambda and the lambdoid sutures, laterally by the lines passing through the parietal eminences, and this is the quadrangular area, which is known as the vertex. Now, vertex is actually a presenting part. By mistake, always we say vertex presentation. Vertex is actually not a presentation. It's a presenting part. So that means this part of the fetal head, whenever it is presenting below, we call it vertex presentation or vertex presenting part, to be more precise. Now, when the occiput becomes posterior like this, so this is the occiput anterior and this is the occiput posterior. Let us see what happens. Now, as we know, in normal labor, occiput anterior, if the occiput is anterior, with the contraction, it goes down, 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 and along with the flexion. This is the flexion, this is extension, or rather deflection. This is flexion, this is deflection, this is extension. We always prefer flexion. Why? Because that occupies the minimum diameter for the pelvis. Okay, for instance, if the head is completely flexed like this, the engaging diameter is suboccipito-bregmatic. That means this is the subocciput, a little below the occiput, this is subocciput, and this is the bregma or center of the bregma. So this diameter actually presents. This is the suboccipito-bregmatic. So when it is flexed, it is quite easy for the head to negotiate because this diameter is only 9.5 centimeter. And the diameter of engagement is the right oblique diameter, which is 12 centimeter. So there is no problem. And then as it descends, it further flexes until it reaches the pelvic floor. And then the internal rotation occurs to bring the subocciput under the symphysis pubis. So rest of the mechanism we have discussed in the mechanism of normal labor. In occipito-posterior, what happens? This is the occipito-posterior, it's a malposition. And right occipito-posterior is more common than the left occipito-posterior. This is the left occipito-posterior, this is the right occipito-posterior. Why right occipito-posterior is more common? Because of the presence of sigmoid colon on this side, and also the dextral rotation of the uterus, not pelvis, uterus. So right occipito-posterior is more common than the left occipito-posterior. Okay, fine. Now let's see what are the problems, what are the things, situation that it has to undertake in occipito-posterior position. If you take the fetus, occipito-posterior means this. You can easily imagine that the fetus's spine is against the maternal spine, and maternal spine is jutting forward like this. So it will never allow full flexion of the fetal head. As I said, the flexion is always welcome so that it occupies minimum diameter in the pelvis. That unfortunately doesn't happen in case of occipito-posterior. So occipito-posterior, right from the very beginning, is disadvantaged to have a bigger diameter for entry in pelvis. And that diameter is suboccipito-frontal. That means from the subocciput, this is the point of subocciput, to the anterior end of the anterior frontal. That means a bigger diameter. So minimum diameter for entry is 10 centimeter. So occipito-posterior has got this disadvantage that the entry point, the entry diameter is bigger in cases of occipito-posterior. That is the first difficulty. So because the head can never be flexed at the very beginning, it is not possible to be flexed because of the clashing between the maternal and the fetal spine. So it starts the process of engagement with a bigger diameter, that is suboccipito-frontal diameter minimum. It can be more than that. Now, as I said, the degree of deflection is always very important. This is the degree of deflection. This is the degree of deflection. In occipito-posterior, the minimum diameter that we can have is this. Okay, suboccipito biparietal is fixed, but the suboccipito-frontal is there. Now, what happens? This diameter will take some time to enter into the pelvis. So there will be a delay in engagement. The first problem that we face, that we anticipate, is the delay in engagement of the fetal head. So it goes inside the pelvis and there is some delay. So always we expect a prolonged labor, prolonged first stage of labor and second stage of labor. I'll explain the second stage later on in occipito-posterior. That is the first difficulty. Second thing is that the unpredictability of the correction of the deflection in the pelvis. Now, this pelvis is not the same gynecoid type of pelvis as we used to see in the anterior vertex positions. Here, the pelvic architecture must be a bit defective, or not defective, it is, subnormal. What type of pelvis encourages this occipito-posterior? It's either the android or the anthropoid type of pelvis. You know that this is the inlet. Android is heart-shaped inlet, and anthropoid is long oval type of inlet. That means the diameter in this directions is less, and there is some amount of shortage of space in the android pelvis. So what happens? This kind of pelvis actually encourages the occiput, the broader occiput, to go back posteriorly, and that's how the occipito-posterior is favored. That is the genesis of the occipito-posterior position. Of course, deflection of the head plays a major role also, but different architecture of the pelvis is also important. So the architecture of the pelvis is a bit deviated from the normal compared to the gynecoid pelvis. Okay. So that's the first thing that we can have in the occipito-posterior position. Now, second thing is that what is the second mechanism of labor? It is the descent with flexion. Now, with this kind of occipito-posterior position, it goes down. Of course, it takes a bigger diameter that I already explained. It goes down, and it touches the pelvic floor eventually. You can see the occiput here. Occiput is touching the pelvic floor. After it touches the pelvic floor, now this occiput has to traverse a long distance of 3/8 of a circle anteriorly to bring the subocciput under the symphysis pubis. So the distance which was covered by the occiput anterior was only 1/8 of a circle anteriorly, like this. I'll show it outside. So in case of occiput anterior, the rotation of the occiput is like this, 1/8 of a circle anteriorly. Whereas in occipito-posterior position, it has to travel after touching the pelvic floor 3/8 of a circle anteriorly, like this. So this internal rotation will take a long time to come to bring the subocciput under the symphysis pubis. Okay, so that means if we expect 3 times the normal time of the rotation of the head, internal rotation of the head, which is a very key mechanism in the mechanism of labor. And that too, it is subject to the availability of the pelvic space. Because as I said, basically the space is less in cases of android and anthropoid type of pelvis. And therefore, it will take longer time for the occiput from here, the posterior, to go to the anterior. Remember, it has to go to anterior, otherwise mechanism of labor cannot happen. And rest of the mechanism, you can conceive that it is the same as the occiput anterior position. So the main mechanism, main problem is bringing this occiput from the posterior to the anterior position. And it's a long internal rotation, 3/8 of a circle or 135 degrees. That takes a longer time. So what is the cue from here? If you can diagnose that you are dealing with a case of occipito-posterior position, early labor, be careful, be prepared to see a longer version of the labor. That means a prolonged labor is inevitable. Why? Number one, because there's delay in engagement. As I said, longer diameter engaging. Second, delay in the internal rotation because it is taking 3 times the normal time of internal rotation. So you can expect or rather anticipate prolongation of the labor, and accordingly you counsel with the patient parties or the relatives waiting outside the labor room. They are so very anxious and eager to know when my baby will be coming out. So explain to them that there is this thing in the passage. However, we are expecting a vaginal delivery. Don't say that we are expecting a normal delivery. We are expecting a vaginal delivery, but the labor has to be prolonged in her case. So explain like this: the her case is special, and therefore she will take some longer time. So this must be explained. Otherwise, the patients also or the relatives always expect that so-and-so has entered after her and she has delivered and come out. Why she's not delivering, etc., etc. So this is the beginning of the counseling process in labor. And today, in the era of compassionate care and respectful maternity care, we are always allowing one companion, birth companion with her. It is always wiser and easier to communicate with her so that she can communicate with the relatives of the patient. So this what I said, the long internal rotation and bringing the occiput from the posterior to the anterior part of the pelvis. This is the normal or favorable outcome, and this happens in most of the cases. Roughly 90% of the cases have this kind of end, and they come out uh, vaginally, spontaneously vaginally, or with minimal assistance. Now, can you call it a normal labor? We always use the two terms very, very lightly. One, as I said, vertex presentation. And I repeatedly say vertex is not a presentation, it's a presenting part. Cephalic is a presentation, and vertex is the presenting part. Okay, similarly, we have presenting part like mentum, like the face, like the brow, etc., etc. So it is unwise to call vertex a presentation. Its vertex is a presenting part. This is one loose statement we always use in public. Second is the normal delivery. Normally हो जाएगा, वो normally हो जाएगा. Normally, you should always use the term vaginally हो जाएगा. Okay. So, you always say that vaginally, we are expecting vaginal delivery, not a normal delivery. Why not a normal delivery? Because we know the normal delivery has 5 criteria. I'm not going to detail, all of you know this. It has to be spontaneous and onset, it has to be at term, it cannot be induced or something like that. It is artificial in this thing, no artificial intervention except episiotomy, without any prolongation, without any damage to the mother and baby. Now, there is a problem that it is having a prolongation of the labor. That is why we cannot call it a normal labor. We can call it a vaginal delivery. Okay. So you can call it a spontaneous or induced vaginal delivery, but do not call it a normal labor. That is the first thing to. So this is the basic difference between the occiput anterior and occiput posterior. Otherwise, you might wonder, थोड़ा सा occiput इधर रहेगा कि इधर रहेगा, इससे क्या फर्क पड़ता है? Lot of फर्क पड़ता है. That is why malposition is such a crucial thing. And as I told you, 10% of all vertex is this, roughly, in early labor, this occipito-posterior position. So actually, we are not diagnosing very much, not many cases. In most of the cases, we diagnose it late. Whenever the labor is prolonged, and whenever the dilatation is not happening at the, or descent of the head is not happening at the expected rate, then we call it we suspect occipito-posterior position. But are there any antenatal clues to the diagnosis of, or rather, just at the beginning, abdominal clues for the diagnosis of occipital posterior? Yes, there are, but it requires experienced eyes, patience, and you have to stay with the patient to understand this. In an evacuated bladder, I mean, the patient has gone to the bathroom and emptied her bladder. If you see a slight suprapubic flattening in the abdomen, you suspect that kahin occiput posterior to nahi hai. Is it occipital posterior? If you see a bit of sigmoid type of abdomen, and the fetus is holding a sigmoid type of position like this, it is not usual like this in the anterior position of the fetal head. In case of this thing, occipital posterior, it's a sigmoid type of, or rather flattening and then elevation. This kind of abdomen, you suspect occipital posterior. Not always, but it is sometimes it is true. While seeing or hearing the fetal heart sound, either in the Doppler or a stethoscope or a fetoscope, are you having to go towards the flank of the mother's abdomen? If you have to go to the flank to detect the fetal heart sound, probably you're dealing with a case of occipital posterior. But all these are probably, because these are all variable factors. It depends a lot upon the fetal position inside the uterus. So not very reliable. So what is the diagnostic point of this thing, occipital posterior? Only it can be done vaginally after palpating the sutures. And that too, it is possible in the late labor. Early labor, it is not possible to palpate the sutures. The station is also high up, and as I said, it takes a longer time to descend, longer time for the internal rotation. And so therefore, occipito-posterior diagnosis is always a challenge. But believe me, it is not that uncommon as we see in clinical practice, quite common. So we diagnose it later. This is the commonest cause of prolonged labor. Of course, along with the deflexed head and occipito-posterior, these two are the commonest cause of prolonged labor today. Now, when I say prolonged labor, I need to be very, very clear about the definition of prolonged labor, which has changed of late. Because in labor care guideline, we have given a lot of time to the first stage of labor. So patience is important. So diagnosis for the in the labor demands a lot of patience, compassionate care, allowing a companion, allowing nutrition, allowing conversation, allowing free movement, etc., all are there. Now, if you ask me, in the management part, is it necessary to put the patient to bed in occipito-posterior position? The answer is no. What we assume in case of malpresentation, I mean a breech presentation or a transverse lie or something like that, we do not keep the patient confined to bed. We allow her to roam around freely in the observation room, I mean the first stage labor room. Why? Because this is just a malposition. It's not a malpresentation. Remember, whenever the fetal head is like this, be it anterior or be it posterior, it is always having this smooth globular structure. So it is unlikely to cause pricking of the membrane and rupture of the membrane and cord prolapse, etc., etc. So that risk is not that much there. So you can allow the mother's movement as per the patient wants, and allow the companion to speak to her frequently, continuously, keep her hydrated, if possible, with a lot of drinking of water, and if not possible, then you have to switch over to the intravenous fluid. So this is only the management tidbits for the time being. Now let us proceed in the mechanism. So as I said, that it takes a longer time to rotate and come to the anterior direction, I mean the occiput. Okay. After that, the subocciput hinges under the symphysis pubis. Then progressive contraction will allow the progressive delivery of the subsequent parts of the fetal head, successive parts of the fetal head. The vertex part will be born, the occiput, the vertex, and then the brow, the face, and the chin. So this is how the delivery happens in cases of favorable circumstances. So that is all clear. Only thing is that you need time, you need patience, you need good hydration, you need good companion, and you need good compassionate care, talking to the patient and relatives continuously. What happens in rest of the 10% of cases? We call them unfavorable circumstances. Why unfavorable? Because there is no progress of labor in those 10% of cases, and we call it arrest. So what is an arrest? Arrest arrest means no progress in the descent of the presenting part, even after full dilatation of the cervix, good uterine contraction, and 1 hour has elapsed. So even after 1 hour of a successful good uterine contraction and full cervical dilatation, if you find the baby is not coming down or not delivering, we call it arrest. And there are 3 types of possibilities of arrest in occipito-posterior positions. And all of them are challenging in management. I'll show you one by one. But for that, you need to understand very carefully, once again, the deflection of the fetal head. As I said, this is the flex position, this is the deflex, this is extension. In occipito-posterior is already disadvantaged because of the fetal spine clashing with the maternal spine. And so it has to be always some degree of deflection. This is the some degree of deflection. While you can see that the occiput is still lower than the sinciput. This is the first mild deflection. You always look at the difference between the occiput and sinciput. My thumb is the occiput and index finger is the sinciput or brow area. So occiput has to be below the sinciput. Imagine the pelvis below. Okay. So this is the first position. That means in occipito-posterior, I mean the minimum diameter that can allow it is the suboccipito-frontal diameter. Okay, 10 centimeter. Now it is going inside, and when it touches the pelvic floor, I mean the occiput touches the pelvic floor. This is the occiput touches the pelvic floor. It starts rotating for 3/8 of a circle anteriorly. That means it is going towards the anterior end of the pelvis. While doing so, it suddenly discovers that from the opposite side, this mild marginal difference of occiput and sinciput have been abolished, and the sinciput also touches the pelvic floor here. You get my point? So the occiput, being the leading pole, starts rotating 3/8 of a circle like this. It starts rotating, and then after traveling half of the distance, it finds that the sinciput on the other end has also touched the pelvic floor. Now, in labor mechanism, as you know, whoever touches the pelvic floor will go anteriorly, or the shortest possible distance it will go. Now, here, both the occiput and sinciput have touched the pelvic floor. Who will go? Then the sinciput is telling occiput that, see, you always go anteriorly, let me go this time now. I want to go. Occiput says, no, you can't go because you're not used to going. So let me go. You stay wherever you are. But in the end, the quarrel continues and nobody goes anteriorly. So both of them stay at the same level. And look at this position. The anterior-posterior diameter of the head is in the transverse diameter of the pelvis, deep inside the pelvis, because that's where the rotation has to happen. It's a phenomenon after the engagement, and the head in the transverse direction. And whatever you may do, whatever trick you may try, there will be no progress of labor even after full dilatation of the cervix. And this is called the deep transverse arrest, or DTA. The famous DTA is here. So DTA means the deep transverse arrest of the fetal head because of the occipito-posterior malposition of the fetal head, and both the poles of the fetal head have gone inside, but nobody moves any direction. This is called deep transverse arrest. So this is the first arrest which happens. It's quite common. I mean, of the arrests, deep transverse arrest is quite common. And whenever you do the diagnosis, how do you do the diagnosis? It is not possible to do the diagnosis abdominally. You have to go vaginally. If you see, you will see that normally what happens, you do not palpate the anterior frontally, you palpate the posterior frontally, but here anterior frontally is easily palpable. You can hit upon the anterior frontally, and the sagittal suture is in the transverse direction, and there is good uterine contraction coming and going, but there is no result, no result in terms of the descent of the fetal head, and it is just getting stuck over there with the caput developing. There are a lot of molding, etc., etc. So a diagnosis of deep transverse arrest is established. So deep transverse arrest means it's a very important issue. Deep transverse arrest has got 3 components. Obviously, first is deep. Deep means deep inside the pelvis. That means it's an engaged head. It can never happen, this kind of phenomenon never can happen in a floating head or non-engaged head. It's a phenomenon of the engaged head. So that's the unfortunate part, that when the head has engaged and you are expecting, everybody is expecting vaginal delivery, the head is arrested. So that is called the deep. Transverse means sagittal suture, as I showed you, is in the transverse direction. That's why it is called transverse. And arrest, as I already defined. So no progress of labor, even 1 hour after full cervical dilatation and a good uterine contraction. So this is called deep transverse arrest. Management, I'm coming later. So this is the first mechanism of first arrest in occipito-posterior position. Now you understand the basic thing is that the difference between the occiput and sinciput. Once again, I tell you, this gap is important. I mean, sinciput is higher, occiput is lower. And if someone of you is wondering why this is important, why this is important to be lower to go into the anterior segment of the pelvis, the reason is simple, because whosoever touches the pelvic floor will be pushed towards the, by the contraction of the pelvic floor muscle, will be forced towards or pushed towards the anterior end. That is why touching the pelvic floor by one point or one area of the fetal head is important. If the entire head touches the pelvic floor, no one moves anywhere. So for any movement, you need a leader, and here the pole is the leader. So occiput is the leader pole, sinciput is another pole, but it doesn't touch the pelvic floor often. Now let us progress this deflection slightly further. Suppose we were talking about the mild deflection, let us call it a moderate degree of deflection. So moderate degree of deflection means the sinciput and the occiput are at the same plane, as you can see, same horizontal plane. So in terms of pelvis, what will happen? They present at the pelvis like this. Obviously, the engaging diameter is much longer, occipitofrontal 11.5 centimeter. So with much difficulty, even if it engages through a diameter of 12 centimeter, that means the right oblique diameter, if it engages through that oblique diameter, what will happen? It will come down with difficulty, the prolonged labor, good uterine contraction, weak uterine contraction by oxytocin, etc. And then ultimately what happens? Both the poles, occiput and sinciput, at the same level, and they are touching the pelvic floor like this. And the same mechanism ensues because both the poles have touched the pelvic floor. No one moves in either direction, and this is known as the oblique occipito-posterior arrest. That means जैसे घुसा था अंदर वैसे जाके arrest हो गया. There is no progress of labor after this, and the arrest ensues eventually, and therefore it is called the oblique occipito-posterior arrest, or OOP arrest. Okay, so the mechanism of labor is the same here. So there is no mechanism after this arrest. So this is the second mechanism of arrest, second type of arrest, slightly less frequent than the deep transverse arrest, but this happens. In the extreme situation, let us take the deflection further. That means now the sinciput is lower and occiput is higher. So what will happen here? What can happen here? This is the position of the fetal head, which is going inside. And as you can expect, the diameter is becoming bigger and bigger and bigger until it becomes a brow presenter. Brow is the extreme of this. Slightly more hoga to brow hoga, slightly more hoga to face ho jayega. So extension, from the flexion to extension, this entire journey is very, very important. And this all depends on the relative movement of the fetal head. So when the brow presentation happens, or just short of brow presentation happens, occipitofrontal or even in brow mentovertical diameter can be there, which is very big, and there cannot be an engagement. But before that, if there is a diameter which can, with difficulty, it can engage like this, what will happen? Now the sinciput will touch the pelvic floor like this. And this is for the first time the sinciput has touched the pelvic floor, and it covers the shortest possible distance and goes backwards. And it's called the, this one. Sinciput turns anteriorly, and the occiput is gone into the sacral bay. This is called the occipitosacral arrest. So this is the kind of arrest where this is the sinciput has touched the pelvic floor, occiput is higher up, Sinciput goes anteriorly. There's no scope of occiput going a long distance like this. Sinciput has touched the pelvic floor. It goes anteriorly, stuck under the root of the nose, stuck under the symphysis pubis, and the occiput is gone under the sacral bay. And this is known as the occipitosacral arrest or persistent occipitoposterior arrest or POP arrest, whatever you call it. So these are the three kinds of arrest that can possibly happen in cases of occipitoposterior position. So what I said is prolonged labor is inevitable. It has to be there. Prolonged labor will be there, and some intervention in all these cases of arrest is necessary now. Okay. So now we have to manage this case. Now the patient is already in prolonged labor. Now there is no question that you can, possibly give her some oral feed or something like that. You have to put her on IV fluid, and some of the cases we may require anesthesia. I'll come to that later. But it's challenging and difficult for the labor to manage, in under the circumstances. Okay, so this now the situation has intervened. So I've already mentioned about the causes of the occipitoposterior position, and I have also explained why this is more common. ROP is more common than the uh, uh, LOP, left occipitoposterior. Theoretically, if you get a question like this, you can divide the answer into power, passage, and passenger. These three conditions can lead to the occipitoposterior position, and diagnosis is very difficult, I know, and I have already explained to you how the diagnosis is possible. Okay. Now let us do the management. What are the possible outcomes unless and until you have a arrest, which happens rarely in 10% of cases, you have a favorable outcome. I mean, the baby is still alive and well, and it has undergone a prolonged labor, all right. But otherwise, it is quite good in, it cries at birth and etc. etc. All these things happen. Now, suppose the arrest, in deep transverse arrest, what do you do? So there are different mechanisms or maneuvers for managing the deep transverse arrest. Okay. And one is the manual rotation, another is forceps rotation. So this is the deep transverse arrest which has happened. And what do? You just put your finger from below. For manual rotation, you need anesthesia. So you need to have anesthesia and need to rotate the occiput anteriorly, but it is difficult to take it anteriorly. So you push the sinciput area like this, and you bring the occiput, try and bring the occiput towards the anterior side. This is called the manual rotation. Followed by, you can also apply forceps when the occiput has come anteriorly and the two serratus suture is almost in the midline. Non-rotational forceps you can try, or else you can try a ventouse. So that is one mechanism, one management. Second management is forceps application, forceps rotation. Now, unfortunately, this forceps rotation is fraught with too much of complication, maternal and fetal, and therefore you have run on this rotational forceps. That is a key-lens forceps these days. We don't do it nowadays. So, number one, you have to, as it is the patient, you have to take the patient to the operating theater, because for manual rotation, even with forceps rotation, need to give anesthesia. And if these one or two mechanisms of manual rotation fails, you can promptly take her for cesarean section at this stage. There are many people who will favor direct cesarean section at this stage, because you think about this, not only this transverse position of the fetal head, which has to be rotated, but also other things are there. That is, for instance, you have to, you have caput, you have molding, difficulty in rotating, and always remember there's a space crunch in the pelvis. Otherwise, occipitoposterior wouldn't have been there. Pelvis में problem है, तभी तो occipitoposterior बना, नहीं तो क्यों बनता? So that is why many people will favor asking the anesthetist that, see, this patient is already in prolonged labor, has taken a long time. It's in case of arrest, already patient is dehydrated. We have been continuously trying to, rehydrate her, resuscitate her, and let us allow a cesarean section delivery. Okay, so that is one mechanism. In all cases of arrest, in non-rotational type of arrest, people used to try key-lens forceps first, but nowadays they have abandoned. And so one or two tries about the rotation, manual rotation, and then go for the cesarean section. Many people will do that. Now, suppose you have an exceptional circumstances, you have a spacious pelvis. It doesn't happen normally, but suppose it happens. then what happens? Then there is something called the phase 2 pelvis delivery. That means like this, persistent occipito-posterior position. So how do you put forceps here? You can put the forceps here like this by the sides of the head, and the pull of the forceps will be something like this, and then this, and that like this. So it's a 3-stage forceps application according to the curvature of the birth canal. So but remember, you have to be a very experienced obstetrician, assessing that the pelvis fetal condition, the availability of space inside the pelvis, etc., etc. And otherwise, if you're not capable of doing so, straight away go for cesarean section. No need to try for this obstetric maneuvers. So I think that you can also imagine the mother's condition. She is dehydrated. She is, having a prolonged labor, maternal exhaustion, etc., etc. Even if you have a complete rotation of the fetal head, then you can have a forceps delivery or a ventouse. Ventouse is better under the circumstances because it also allows a small degree of rotation in almost all the cases. So I think that is the key mechanism of labor, and the bits and pieces of management of arrest cases and management of prolonged labor, etc. I think we'll take up some questions if there are some questions. Yes, one question is, why does the head take long internal rotation and not short 1/8 to opposite direction? Very intelligent question, I must say, but the answer lies in the leadership theory. Leadership theory means in labor, what happens? This is the lower pole of the fetal head. This is the lower pole of the fetal head. And this is the occiput, which is conically projecting part, which actually irritates the pelvic floor like this. And when the pelvic floor contracts, it moves forward. It moves forward in each contraction. That's how the internal rotation happens. So you have to understand this basic mechanism of labor, that internal rotation is basically a leader-guided movement. And we have to have a leader in the fetal head, or this is called denominator. Denominator, the main job of the denominator is to produce movement towards the anterior direction. So this is the pelvic floor on which the occiput is pricking, and with every contraction it is coming down and pricking, and it responds by contraction like this, like this, like this, like this, and the internal rotation happens. This is the mechanism. Now think about this, that the occiput in occipito-posterior position, or even in occipito-anterior position, occiput is the pricking part or the leading pole. Now suppose the sinciput, this occipito-posterior, this is the anterior, this is the posterior direction. Anterior, sinciput is high up. It is not touching the pelvic floor. So naturally, it cannot rotate anteriorly or posteriorly in any direction. It has to rotate. This one has to rotate. The occiput has to rotate. So this is the leadership theory in labor management, and that is why the head takes long internal rotation and not short 1/8 to opposite direction. Short 1/8 rotation only happens in cases where it's extremely deflexed head, and sinciput touches the pelvic floor, then only is it possible to go for the movement of the sinciput, otherwise not. I hope you get your answer. Any more question? I can't see any other question. I think that's all. So I'll finish here and go to the case discussion. Sir, Dr. Ashok Kumar, are you there? Sir, your comment, please, and then we will go to the case discussion.
Yes, sir. Thank you very much. And you have really explained in very simple words and easily understandable. I hope students have understood the steps and the procedure and mechanisms of occipito-posterior and what are the problems they face in this situation. So thank you very much, sir. And I do hope that student will give us feedback also by sending us the messages that what they feel about all these things. The second thing is we are covering multiple times these type of procedures, but with one go it cannot be understood. It needs multiple revision and reading. So that is what we are also doing, and try to understand from different teachers that and then small things can be emphasized and we can understand that what is important at this stage. So
Absolutely.
thank you very much. And now we move on to sir. So please carry on the case. Yes.
Yes, yes. I'll do that. I'll do that. I'll call the. Could I have this thing? The presenters. We have Dr. Monica and Dr. Bithika. Kindly open your video, please. We can't see you. Dr. Monica and Dr. Bithika, are you there?
Yes, sir.
Oh, okay. So Monica and Bithika are going to present a case on, case presentation, a case on anemia in pregnancy, third trimester of pregnancy. And our examiners are, apart from myself, Dr. Kavita Singh. Madam, are you there? Yes, she's there. I can see her. Yes. Dr. Kavita Singh, you kindly rename yourself. You're still showing as speaker. And then the other examiner is Dr. Shakun Singh. Dr. Shakun Singh is here. Dr. Shakun Singh is the professor of OBGYN at LLRM Medical College, Meerut. Dr. Shakun Singh is here. I think she's not. Hello, madam. Hello, are you there from Meerut? And Dr. Jitesh Shah.
Yes, sir. Good afternoon.
From Surat, yes. Dr. Jitesh Shah, I can see. So I think myself and Dr. Jitesh Shah will be guiding you through the case presentation, and their coordinator is Dr. Moushumi Das, Senior Consultant, Tata Main Hospital, Jamshedpur. Moushumi is there already. I can see her. So students, you are going to present this case, Dr. Bithika Patnaik and Dr. Monica Nautiyal. Kindly start your presentation. You're already full screen. Kindly say hello so that we can test that you are audible.
Hello, sir.
Thank you. You are audible and you can start now. Case presentation.
Yes, sir. Good morning, everyone. I'm Dr. Bithika Patnaik, third year DNB resident, Tata Main Hospital, Jamshedpur. Good afternoon, everyone. I'm Dr. Monica Nautiyal, a third year DNB resident from Tata Main Hospital, Jamshedpur. Today, we are going to present a case on anemia in pregnancy. Our coordinator is Dr. Moushumi Das Ghosh. My patient, Mrs. X, wife of Mr. Y, 20-year-old female, Hindu by religion, educated till 8th standard, homemaker by occupation, belonging to lower middle class family, hailing from Baridi, Jamshedpur. She is gravida to para 1, living 1 at 34 weeks of gestation, a booked case of our hospital. Her last menstrual period is 8th of April 2024, which makes her EDD to be 15th of January 2025. She presented to the OPD with chief complaint of easy fatigability since 1 month, breathlessness on exertion since 15 days, swelling over lower limbs since 7 days. My patient was apparently all right 1 month back when she gradually developed easy fatigability on exertion, which gradually increased over the last 15 days to an extent that she gets easily tired with routine household activities. She also complains of breathlessness on exertion since 15 days, which was followed by swelling of lower limbs since 1 week, which decreased on rest. There was no history of palpitation, chest pain, orthopnea, no history of bleeding per vaginum, bleeding per rectum, easy bruisability or petechiae, no history of burning micturition or increased frequency of micturition, no history of passage of worms in stool, no history of reduced appetite or constipation, no history of yellowish discoloration of the eyes or skin, no history of chronic cough, hemoptysis or fever. Coming to history of present pregnancy, she is conceived naturally. The pregnancy was confirmed by home-based positive urine pregnancy test after 1 month of missed period. Dating scan was done at 2 months and her dates were told to be corresponding with period of gestation. There was no history of excessive vomiting, pain in abdomen, bleeding PV, fever or burning micturition, no history of drug exposure, radiation exposure, folic acid tablets were taken. A second scan was done at 3rd month of gestation, which was said to be normal. The bookings investigations which were done were within normal limits. She felt her fetal movements first at 5th month of pregnancy. Third scan was done at 5th month of pregnancy, which was told to her by the doctor that there were no congenital anomalies. Injection TD taken. Lab investigations were done. Were within normal limits. There was no history of blurring of vision, headache, pain in abdomen, bleeding per vaginum, leaking per vaginum. But the patient was non-compliant on iron and calcium tablets. In the third trimester, the patient perceived fetal movements well. Fetal well-being scan done at 8 months was normal. BP readings were normal. She did not take iron tablets regularly, as said by the patient. There was no history of burning micturition, headache, blurring of vision, bleeding per vaginum, leaking per vaginum, or pain abdomen. Now she is presented in gynae OPD with chief complaint of easy fatigability, breathlessness on exertion, and swelling over lower limbs. She has attended her menarche at 13 years. She had a regular cycle which came at intervals of 28 days and lasted for around 4 days, and had a moderate flow which was not associated with clots and dysmenorrhea. Her last menstrual period was 8th of April 2024 and her EDD is 15th of January 2025. She is married since 3 years. She had a non-consanguineous marriage and there was no history of any contraceptive usage. Coming to past obstetric history, her last delivery was 1.5 years back in July 2023. She had an institutional vaginal delivery and delivered a 2.5 kg female child who is immunized well and is currently doing well. Her intrapartum, her antenatal, intrapartum, and postpartum period were uneventful, and the interconception period is 8 months. Coming to past history, she is not a known case of diabetes mellitus, hypertension, TB, thyroid disorder, cardiac disease, coagulation disorder, or any other medical comorbidities. There was no history of parenteral iron infusion or blood transfusion. No significant surgical history was present, and there was no history of any drug intake. Coming to family history, there was no history of repeated blood transfusions or any bleeding disorders in the family or any history of chronic disease or genetic disorders in the family. Now, nutritional and dietary history, she consumed mixed Indian diet, which is predominantly vegetarian. Total calories consumed by her was 1985 kilocalorie per day, and it was according to the 24-hour recall method, and calorie deficit was 865 kilocalorie per day. Total protein consumed by her was 34.4 grams per day, and protein deficit was 28 grams per day. Now I'll hand over to my colleague Monica to present the examination part.
Patient was comfortable at the time of examination, conscious and alert to time, place, and person. She seems moderately built and averagely nourished. Her height was 150 centimeter. Her pre-pregnancy weight was 49 kg. Her current weight is 51 kg. Her BMI is 21.7 kg per meter square. Weight gain during pregnancy is 10 kg. Severe pallor was present. Bilateral pitting pedal edema was present. No icterus, clubbing, cyanosis, and lymphadenopathy. There was no evidence of glossitis, stomatitis, nail changes, or hair changes. Her temperature was 98.60 degrees Fahrenheit. Her pulse was 108 beats per minute, which was regular in volume. No radial and no radiofemoral delay. Her blood pressure was 110 by 70 millimeter of mercury on right arm in sitting position. Her respiratory rate was 16 cycles per minute. Her GBP was not raised. Her breast and thyroid examination was normal. On systemic examination, cardiovascular system, respiratory system, and CNS system was normal. Now coming to per-abdominal examination, on inspection, abdomen was uniformly enlarged. All quadrants moved equally with respiration. Umbilicus was central and everted. Linea nigra and stria gravidarum were present. No scar, sinuses, and dilated veins seen. All hernia orifices were intact. On palpation, fundal height was 32 to 34 weeks, which corresponds to her current gestational age. Symphysia fundal height was 33 centimeter. Abdominal girth was 32 inches at the level of umbilicus. Uterus was relaxed on fundal grip. Soft, broad, non-palatable part felt, which is suggestive of the breech. On right lateral grip, smooth uniform resistance felt, suggestive of back. On left lateral grip, irregular knob-like structure felt, suggestive of left. On fourth pelvic grip, hard tubular fetal parts felt, suggestive of head. On second pelvic grip, head was not engaged and head was with 5 by flight dilatable. Amount of flicker appears to be adequate. Fetal movements were felt. On auscultation, fetal heart sound was found in right spino-umbilical line at the rate of 150 beats per minute, which was regular in rhythm. Now, summary of our case is a 20-year-old female gravid to para-1 living one at 34 weeks periods of gestation belonging to lower socioeconomic status with short interconception period, which she complained of, they presented to us with a complaint of easy fatiguability, breathlessness, and swelling of bilateral limbs. She was non-compliant to iron tablets with deficient calorie and protein intake. On examination, tachycardia, severe pallor, and bilateral sweating pedal edema was present. So, our provisional diagnosis is a 20 years old young female, gravida to para-1 living one at 34 weeks of gestational age with single life fetus with cephalic presentation with severe anemia not in failure, probably nutritional cause.
Thank you.
Okay. Okay, Bitika and Monica. First of all, you presented very nicely. It was as it is offline, so we, the examiners and teachers, are sitting at distance. Otherwise, in during exams, there will be multiple questions when you are presenting history. And first thing, like you started, there are small things which we have to keep in mind, like. You need not to tell the patient is female when you are saying that they're presenting a case of antenatal case. So you are right now, you're not in medicine or surgery department, you are in OBGYN, you're presenting a antenatal patient. So saying female in diagnosis right from the starting to the final diagnosis is not needed. Secondly, Monica has nicely summarized the relevant points as far as the findings are concerned. But when you speak out about your diagnosis, you have to be very particular with the final thing. So your patient is by dates today, she's how many weeks of gestation?
34.
34 weeks.
She's, no, I'm asking students, sir.
Okay. Huh.
Yeah,
34
Bitika?
weeks, ma'am.
34 weeks, ma'am.
Okay, 34 weeks. So 34 weeks with severe anemia, right? And she
Yes.
presented to you with breathlessness and um, can you correlate the symptoms with the signs? Any one of you?
Yes, ma'am.
Sorry, ma'am, could not get your question.
Like the breathlessness and you said easy fatigability. So what were the signs which were correlating with the symptoms? This is what I'm saying. You have examined it.
Yes, ma'am.
Ma'am, see, on examination, we could clinically we could find severe pallor. There was edema in both her limbs. Bilateral pitting edema was present.
Mm-hmm. And so you
And
have checked your pitting edema in limbs anywhere else?
Yes, ma'am. It is physiological in pregnancy also.
Hmm?
ma'am is asking to say.
Yes,
कहीं
ma'am.
और देखा कहीं और any मतलब edema आपने check किया, so have you checked it some other sites also? Does it have any relevance? What are the other sites which we look for edema during pregnancy?
Yes, ma'am. We
Yes,
can
ma'am.
also look in the shin of the tibia, dorsum of the foot.
Mm-hmm.
We can see in parities in the vulva also. We can check for edema.
Mm-hmm. Okay, so you this is one thing. Anything else in the breathlessness?
She complained of breathlessness on exhaustion.
Mhm.
She had told us that when taking 2 flights of stairs, she was
Mhm.
feeling breathlessness.
Okay. So have you examined anything else apart from being the pallor and the anemia?
Yes, ma'am. We checked her
Yes.
general physical appearance, like hair, her nails.
No. For you said no, she is breathless. So would you
We-
like to examine?
He auscultated the chest.
Mm-hmm.
Ma'am.
So what
To
were
look
the
for-
findings?
Chest was clear, ma'am.
Bilateral vesicular breath sounds were present. No
Mm-hmm.
heartbeat sound were there.
Mm-hmm. Any murmur?
Ma'am,
We could not appreciate the murmur, ma'am.
Okay. What type of murmur is likely in case of severe anemia?
Ejection, systolic murmur.
Okay. So anyways, you have examined and you have come to the diagnosis. Now, I think Dr. Jitesh and Dr. Shakun is also there. So, Doctor, you can take up with the investigation and management part.
Yes, ma'am. Yes, ma'am.
Yeah.
Meenal and Gitika, why do you say your case is a case of severe anemia?
Ma'am, first of all, because of her symptoms and clinically it appeared she was white, ma'am.
No,
On
she was
exam-
white, but clinically also, there are some features by which you can assess whether your patient is having moderate anemia or severe anemia. What are the signs of severe anemia?
Ma'am, in Palmar crease,
Palmar
That is
creases were not visible.
not visible.
That's why we have said.
Okay. And otherwise, academically, how do you classify anemia?
Ma'am, according to WHO, there are three classification: mild, moderate, and severe. Mild is hemoglobin from 10 to 10.9 grams per deciliter. Moderate is from 7 to 9.9 grams per deciliter. And severe is less than 7 grams per deciliter. And according to ICMR, there is another category which describes severe anemia. Very severe anemia is less than 4 grams per deciliter.
Okay. Then how will you manage your case? That means how will you investigate and how will you treat?
Ma'am, first and foremost, we'll do investigations, a hemoglobin or a complete blood picture.
Hmm.
And
Will you admit her?
yes, sir.
Will you admit or a OPD basis?
No, sir, we will admit her as she was having
Okay.
symptoms.
Okay. Now, how will you investigate?
So first, we'll look for the complete blood picture to see for the hemoglobin, to see for the RBC, RBC volume, hematocrit, blood indices like MCV, MCH, MCHC, and to see the peripheral smear also, so that we can know the severity of anemia and type of anemia.
How is physiological anemia different from pathological anemia, Meenal?
Ma'am, physiological anemia on peripheral smear, there will be normocytic, normochromic anemia. And
Yes.
in physiological anemia, hemoglobin concentration is will not be less than 11 gram percent in first trimester, and it will not less than 10 gram percent in second
And third trimester.
Okay. And anything
Hematocrit
about
will
hematocrit? Yes.
hematocrit is 32. The hematocrit will be 32 and RBC volume will be the hematocrit will be 30 and RBC volume will be 3.2 millions per cubic millimeter.
Okay. Other than RBC, hemoglobin, CBC, what other investigation would you like to do in this patient?
Ma'am, urine investigation to look for UTI or any cast cells to look for chronic kidney disease. We can do stool examination for occult blood.
Retic count, ma'am, and serum ferritin levels. We can do these two investigations.
What does serum ferritin level indicates?
Ma'am, serum ferritin normal is 50 to 155, and if it is less than 30, then it is indicating that less than 30 indicates iron stores are depleting, and it is an indication to start treatment. But if it is less than 12, then it is diagnostic of iron deficiency anemia, that iron stores are depleted.
Okay.
When does the ferritin level gives false result?
Sir, in inflammation or infection, in cases of infection or any acute inflammation.
Yes.
Any other investigation, Meenal and Geetika?
Ma'am, bone marrow biopsy is not routinely done. It is very rare.
Tell about general investigation also, not related only to anemia. She is an antenatal patient, 34
Yes,
weeks of gestation. Speak about other investigation also, na?
Yes, ma'am.
CBP peripherals ma'am, serum TSH levels, urine routine microscopy, and
We also do, ma'am, OGCT, postprandial,
DIPSY test.
sorry, DIPSY, according to.
And
How do you do DIPSY?
we will ask patient to
To
drink
drink
75
75
gram
gram
of
of
glucose and 300 ml of water, and we will check the blood glucose level after 2 hours.
Okay. Then this was about the maternal well-being. What about the fetal well-being?
Ma'am, for fetal well-being, there are high chances there in anemia. There are high risk of preterm labor, PPROM, IUGR, preeclampsia, abruption. So we will monitor that accordingly, and we will do the growth scans, and we will tell her to go immediately ask for help if she goes into labor, preterm labor.
If she is coming to you in OPD, she is not having labor, I think, in your provisional diagnosis. She is not in labor, no?
She was not in labor, ma'am.
Yes. So how will you assess the fetal well-being?
Symphysis fundal height, ma'am.
No, I'm not asking about clinical examination. You have already spoken about that. We are
Ma'am,
asking about investigation. क्या कराओगे fetal well-being देखने के लिए?
ultrasound, ma'am. First of all, growth scan.
With
If,
Doppler
with
velocimetry
Doppler.
also, है ना? Because your patient is at high risk of having FGR.
FGR, yes, ma'am.
So you will go for Doppler also.
I think here one point, Dr. Shakun, that we can ask like this, that right now the patient is 34 weeks with severe anemia. So what is bothering?
Yes.
What is bothering you? And whatever is bothering you, you will, focus your investigation and management as per the presentation. So she is a severe anemia. So quickly you will send investigation, quickly you will classify. Then what next?
Yes, ma'am. Regarding anemia also, we will first priority is anemia only, है ना?
Yeah.
But the baseline investigation has to be sent also. We are admitting the patient, and straightway we will start the management also, depending upon the investigations.
So Bitika and Monica, you can take up like this. What is bothering you and how we are going to manage now?
Dr. Singh and Dr. Shah, I'd like to request you to kindly discuss the differential diagnosis, please. Because as of now, we are discussing only iron deficiency
Anemia. Yes, sir.
But there are other possibilities, other anemias also, which has to be differentiated by the student. And secondly, that depending too much on the symptoms and signs, and also for that matter on the hematological indices, we are not always able to diagnose the type of anemia. Degree of anemia, severity of anemia is okay, but type of anemia may need some hematological investigations. Like, for instance, differentiation from thalassemia, they should know. So what are the differential diagnoses in this case, and how do they rule out them?
Yes.
Ma'am, if in peripheral smear it comes out to be microcytic hypochromic anemia, then we have differentials like thalassemia, sideroblastic anemia, chronic disease, iron differentials of IDA, and lead poisoning, copper deficiency. These are causes of microcytic hypochromic. And to differentiate between thalassemia.
Yes, go ahead.
To differentiate between iron deficiency and thalassemia, we can check for Menzel's index, which is MCV by RBC count.
If it is less than
13, it is thalassemia. If it is more than 13, then it indicates towards iron deficiency anemia.
You said complete blood count, isn't it?
Yes,
so does that give any clue to the diagnosis between the thalassemia and the iron deficiency anemia?
Yes,
And what are the components of CBC, a complete blood count? What
sir.
report do you expect in a CBC report?
So hemoglobin, differential leukocyte count,
Hmm.
and platelet count, and
Hematocrit.
RBC indices, sir, which include MCV, MCH, and MCHC. In ID and with differentiating between
Those
ID
things
and
we have
CAS.
discussed. What about RDW, red cell
Yes,
distribution?
Distribution.
Yes, sir.
It increases in iron deficiency anemia
remains nominal.
in thalassemia.
Okay, so I think
How will you interpret?
you interpret the case of high versus low red cell distribution width. Is it possible to point towards some diagnosis and then you later on confirm by some other definitive investigation?
Yes, sir.
So, increased RDW indicates towards iron deficiency. We can confirm by doing iron studies for definitive diagnosis.
Okay, they are also misleading at times, as you have correctly said about the ferritin, but the other things like serum iron and TIBC, etc., that those we have stopped investigating because they are too misleading. So I think that hematological indices, the peripheral smear, the RDW value, and ferritin, they are the four components for diagnosis, going from a differential to a positive diagnosis. And these individually you should know. And it is always wise to discuss all other types of anemia because it's all right that iron deficiency anemia is still the commonest type of anemia in our country, but then you must know about the anemia of thalassemia and anemia of other causes.
Yes.
Yes. Sickle is also very
Sickle cell is
Yes, sir.
common. Yeah.
So
Acute
now,
onset breathlessness goes with many a time with sickle.
Yes.
Sickle
Yes,
cell,
ma'am.
yes, ma'am.
Yeah. So I think Deepika and Monica, you have nicely presented your patient now. You have reached the diagnosis. So what is the diagnosis? Have you investigated this patient already?
Yes, ma'am. We have investigated this patient.
So she's iron deficiency?
Yes, ma'am. She is iron deficiency.
Okay, so let's stick to the cause which is already diagnosed. So we are going to manage now.
Yes, ma'am.
Ma'am will admit the patient and as she is already 34 weeks, so we'll have blood transfusion for her, ma'am.
Hemoglobin, you said is 6 grams, na? What?
Yes, ma'am.
Yes,
6
ma'am.
gram percent.
6 gram percent.
Yes, ma'am.
Hmm.
Because in treatment, if it is more than 34 weeks and she's having a severe anemia, then we go for blood transfusion, ma'am.
Okay. Fine. Anything else?
And we'll check if she's going into preterm labor. We'll be doing the fetal well-being. CTG will be NST will be doing for the patient.
Mm-hmm. Yes. Precautions during
So suppose this is a case of severe anemia in third trimester. Which are the different options for management?
Yes.
So parental iron can be given in mild to moderate anemia in third trimester. Moderate
How will you
anemia.
select a case?
So if you know,
Whether you will use iron therapy or blood transfusion.
so the patient is non-compliant say is intolerant to oral iron tablet, or they want.
No. Sir is asking, sir, if it is the patient is more than 34 weeks and she's having hemoglobin
Severe
between
anemia.
sorry, sir.
So Bitika, it is
Severe
about the
anemia.
symptoms also. So 34 weeks, fully symptomatic patient, hemoglobin
Yes, ma'am.
6 grams. Asymptomatic patient attending OPD with hemoglobin 6. you have a wide range of options available. So that is what sir is asking you.
Ma'am, if the patient is less than 34 weeks and she is presented with 6 gram hemoglobin and there is no impending signs of heart failure, then we can go for parenteral iron therapy, ma'am. But if she is more than 34 weeks, we'll go for blood transfusion.
Which are the prerequisites before giving blood transfusion?
First of all, we'll confirm the diagnosis of anemia and we'll ask for any history of allergy or anaphylactic reactions. We'll have cross matching.
Take the consent of the patient, and we should be transfusing the blood in a well-equipped facility, so that if any
Reaction
reaction
occurs,
occurs, we can
treat the
patient accordingly.
Which type of blood product you will prefer, whole blood or packed RBC in this patient?
Packed cells.
Packed RBC. Okay. And in how much duration the 1 unit of blood should be transfused?
In 4
4
to
hours.
5 hours. 4 hours.
4 hours, ma'am.
Okay. What allergic reactions can you see in this patient after blood transfusion, if happens?
Now fever, rash, tachycardia, generalized itching, or breathlessness.
Okay. And in severe reactions?
Ma'am, we will stop the blood transfusion immediately.
Nee,
And
what can be the manifestation of severe blood transfusion reaction?
ma'am, breathlessness and fall in SpO2 levels.
No. Have you seen hematuria in a case of blood transfusion?
No, ma'am.
You have not seen? That is the severe blood transfusion reaction. It can affect kidneys also and can cause acute renal failure. So we have to be very vigilant while transfusing blood.
Yes, ma'am.
Okay.
Yes, ma'am.
Then how will you
How
proceed?
many units will you transfuse?
Sir, in our case, at least 2 units.
How will you give? At which duration?
So first we will properly cross-match the blood, and then we will transfuse the patient first slowly at the rate of 14 to 15 drops per minute. Then after 15 minutes, we will increase the flow rate, and we will finish it within the 4 hours.
Okay. When will you give second unit?
So we will give it the next day, sir.
When will you send repeat investigation?
Sir, at least after 3 to 4 hours. 6 hours. Last transfusion to 4 hours.
Okay, nice. You have managed patient. The patient is stable, accepted transfusion, then it's fine. But if suppose she goes in labor, then how you will manage?
Ma'am, suppose
Intrapartum electronic fetal monitoring, continuous electronic fetal monitoring. We should avoid repeated vaginal
examination, and we should start antibiotic prophylaxis as well. We should keep the patient in propped up position. Oxygen also we should give
fluid
fluid restriction should also be done.
And we will make the blood ready in the blood bank.
In the intrapartum period, we can cut short the second stage of labor by
And we would check the keep checking the chest.
Chest.
intermittent auscultation. Yes,
Chest
ma'am.
auscultation is also very important.
To look for crepitation, to see if
She is
it's
not
going into heart.
failure. It's very
Okay.
high chances are there.
Okay. Okay. So you'll be ready with
And then active management of
Third
third
stage.
okay. So during delivery, you would like to look for a CCF, that patient doesn't go into failure. At the same time, you are watchful for the uneventful delivery.
Yes,
So this is 34 weeks newborn. Any prophylaxis would you like to take earlier because the patient is with you?
yes.
The wards?
Steroid, we can administer steroid if she is going into labor.
चलो अच्छा ठीक है डिलीवर हो गया हैंड ओवर हो गया पीडियाट्रिशियन को एंड देन एनीथिंग एल्स यू आर वरीड फॉर
Ma'am, we are worried for PPH.
So how are you going to manage it and how are you going to prevent it? How do you do every day in the labor room?
Ma'am, we will prevent it by doing active management of third stage of labor. In it, we will, after delivery of the anterior shoulder, we will give oxytocin within 1 minute. And we will do the control cord traction. We will deliver the placenta by control cord traction. And we would check intermittently for the tone of the uterus.
Okay, so you won't pull Brandt Andrews आपने कर लिया
Yes.
and
Yes,
still
ma'am.
the patient is bleeding. What next?
So now we will look for the first. We will look for the local cause of the vaginal bleeding. First, we will look for the tone of the uterus and local cause of the vaginal bleeding. Look for the any tear and we
Okay,
will
so
manage
now,
accordingly.
yeah, so now your patient will turn up from not only severe anemia during pregnancy, now it is an PPH you have to manage in a case of severe anemia, right?
Yes, ma'am.
Yeah. So what next?
Ma'am, we will give injection in oxytocin 20 unit in 500 ml of RL. And we will also get 1 gram tranexamic acid slow IV within 10 minutes. And then intermittently we will also look for the
Yeah, you have diagnosed that it is atonic. Actually, atonic is very common in severe
ma'am.
anemia cases, na? Yeah. So something you can do on the table itself.
Ma'am,
You
bimanual uterine
foot massage.
We'll do bimanual uterine massage. Call for help. We will keep the we will arrange the blood products.
Blood and blood products.
To IV both, to wipe both cannula in both hands. And
Cardiac prosthesis.
and if after oxytocin it is not responding, then we will give another drugs like carboprost and also give here. And we will do 250 microgram iron and repeat it after 15 minutes.
15 minutes.
Up to 8 doses, we can repeat it.
Okay.
Other than oxytocin and carboprost, what other drugs do you use, which you use commonly in your labor room?
Misoprostol, ma'am.
So why you are not saying that?
Yes, ma'am.
What is the standard dose of misoprostol for management of PPH?
Ma'am,
800
microgram.
microgram per rectally.
Per rectally, yes.
So
And what are the ठीक है चलो.
Yeah, ठीक है पूछिए.
Okay, now this was your patient in third trimester. Na? She was at 34 weeks of gestation with severe anemia. Suppose same patient came to you at an earlier gestation, 30 to 32 weeks. What would be your management at that point of gestation?
Then we would give parenteral iron transfusion to her as she was non-compliant to
Oral iron.
tablets.
You will prefer oral iron or parenteral iron?
Parenteral, ma'am, because she was non-compliant to oral iron.
Okay, okay. So what type of preparations are available and how will you administer these preparations?
Iron sucrose and ferric carboxy
Maltose are commonly used, ma'am.
Yes.
Iron sucrose is given as 200 milligram and 200
ml of normal saline.
and we should
Okay.
administer it within 15 to 20
Minutes,
minutes.
maximum 600 milligram per week, and it can be repeated every alternative day.
Okay. Then is a test dose required before giving iron sucrose?
No, ma'am.
No, ma'am.
For iron
Huh.
sucrose, not.
So how do you administer that iron sucrose solution?
Only 200 ml NS.
At what rate?
Now this should over 15 to 20 minutes we should empty.
Okay. Initial 1 minute, it should be administered at a
Slower rate.
slow rate. How much drops per minute?
15.
For first 1 minute, it has to be very slow. 8 to 10 drops per minute. Hai na?
Yes, ma'am.
And then we will increase the drop rate.
Yes.
So that the whole solution has to be completed within
20 minutes.
20 minutes, maximum within 30 minutes. Why do
30
we want
minutes.
to complete it within 20 minutes? What happens if the duration is extended?
Food oxidation occurs now. It becomes toxic to the tissues.
Okay, and how do you calculate the dose? How much iron we
Ma'am,
want
by
to give?
Scans on his formula, ma'am.
What is that formula?
2.4 into target hemoglobin, actual hemoglobin, into the pre-pregnancy body weight plus 500 for iron reserve.
Okay. And how do you
If
give
you don't know the
carboxymal?
Sorry, sir.
if you don't know the pre-pregnant weight, then which weight will you take?
We'll take the standard weight of the female.
Usually patient comes direct in the pregnancy, barabar? And we are
Yes.
not knowing the pre-pregnant weight.
Okay. First visit.
First visit. Right? First visit in the first trimester. Now you answered the madam's question. Ferric carboxymaltose.
Ma'am, ferric carboxymaltose can be given higher dose up to 1000 milligram in 200 a normal saline, and it is completed within 15 minutes.
Okay, and how much maximum dose can we give it in 1 week?
No, only one dose in 1 week.
Yes, only 1 dose in 1 week. So which is better, you think? Iron sucrose or carboxymaltose?
Carboxymaltose, ma'am, because it avoids the repeated transfusion.
Okay. Then what is the rate of increase in hemoglobin when you give iron sucrose?
Same for oral and parenteral, ma'am.
Same for oral. Then why we are preferring parenteral preparations?
Because 100% guarantee of compliance, ma'am.
Okay.
And it will bypass the intestinal circulation. There is GI tolerance is also issue is not there.
Okay. Suppose you are giving parenteral therapy and your patient is not responding. After 3 weeks also, the hemoglobin is not rising. What is the first indicator of rise of hemoglobin?
Reticulocyte count, ma'am.
Okay. Or
feeling of well-being.
sense of well-being,
Well-being.
improved appetite.
Yes.
Okay. Suppose your patient is not responding, then what other differential diagnosis will you keep in your mind?
We can think of malabsorption. Leukemia, ma'am.
Straight away leukemia?
If it is not, if she is not responding to iron therapy, then we can look for other causes of anemia.
Yes. What are those?
Ma'am, megaloblastic anemia, folate deficiency anemia,
Yes.
thalassemia,
Thalassemia. Yes.
sickle cell. Other causes we can rule out. Sickle
Have you
cell.
heard of anemia of chronic infections also?
Yes, ma'am.
And infection anywhere in the body can also cause anemia.
Yes, ma'am.
So how will you differentiate between these other causes of anemia? कैसे
Ma'am,
पता
usually
लगाओगे? What is the screening test that we use to detect thalassemia?
ma'am, Nestroff test.
What is that test?
Once in a tube, hypotonic solution is taken, hypochromic and
Ma'am, we take tubes. In one, we take hypotonic solution, and another distilled water. And as the principle is the
hypochromic cells undergo lysis.
in hypotonic solution, normocytic, normochromic cells, they undergo lysis. Whereas the microcytic hypochromic cells, they do not undergo lysis because of the change in the surface area. And while in distilled water, both type undergo lysis.
Okay.
So, nicely answering all the questions. I think 2-3 minutes more to go. So,
okay.
Yeah, now your patient has delivered nicely. You have managed PPH, and now the patient is in postpartum. Your patient. What
Yes, ma'am.
special care would you like to take in this case?
Ma'am, first 4 to 6 hours we'll keep her under monitoring because there is also risk of cardiac failure and sepsis, also subinvolution of the uterus. We need to monitor.
Postpartum period, we will look for this.
Yeah, please speak loudly.
Ma'am, in the postpartum period, we will be monitoring the patient closely for at least 4 to 6 hours post delivery, so as to check the so that the patient does not go into cardiac failure, because immediately postpartum also is a high risk period for cardiac failure, and there is chances of subinvolution of uterus, and we'll also initiate antibiotic if episiotomy is given, because there is risk of peripheral sepsis also, and we'll ask patient to ambulate in order.
There is a risk of DVT is also there.
Venous thrombosis is also there. Risk
Would you
of
like to do
venous
reassessment and recheck of investigation and then further add on to your management? Would you?
Will you repeat CBC?
Yes, ma'am.
Have you heard of postpartum anemia correction before sending her home? Would you
Yes,
like to
ma'am.
do something more? Yeah.
Yes, ma'am, we would give her iron tablet and we would advise how to take iron tablets.
Okay. Iron tablets for how long?
At least 180 days in the postpartum period.
To replenish the iron.
That is for anemic patient or non-anemic?
So for all the patients.
This is to restore
Okay.
the.
And madam is asking about postpartum anemia. If mother is anemic again, how will you define postpartum anemia?
If the hemoglobin is less than 10% in the postpartum period.
Okay, so when will you repeat CBC after delivery in this mother?
But after 4 weeks, we will repeat hemoglobin. We will first give her oral iron tablets twice daily.
Will you not repeat immediate after delivery or within 24 to 48 hours?
Yes, sir, we'll do that.
And then you will define
Yes,
the
sir.
post as whether it's anemic or not.
Yes, sir.
So this is going to help you in sending her home with an good iron stores. At the same time, any special care for the newborn and contraception, if you want to add on.
Yes, ma'am. Yes, ma'am. Contraception advice.
Okay, what advice would you give in this patient? She had one daughter of 1.5 years at home. Now this is a newborn of 34 weeks. She is delivered, na?
Yes, ma'am.
Yes.
Would be progesterone only pills.
Or dipomedroxyprogesterone.
Yes, Dampa can be given.
Okay, how do you give?
Ma'am, I am every 3 months.
150 milligram IM injection every 3 months.
Okay. Something you have mentioned in your diagnosis slide was about the nutritional cause of this anemia. So would you like to give some dietary advices, very clear, and which is very, very important in your case?
Yes, ma'am. We would first advise her to take iron tablets. As she is not able to take before meals, so we would advise her to take after meals, 1 to 2 hours after meals, and we would advise her to take with citrus water, and we would advise her to take jaggery,
Iron-rich
vegetables,
spinach, fenugreek, groundnuts, jaggery, and non-veg diet also, because it has heme iron. And we'll also advise her to cook her meals in cast iron utensils.
Okay, what advice would you like to give her family members and husband? Last question, huh? Then we'll summarize it.
I just wanted to ask you one thing, the candidates, that the same factor of non-compliance which she had suffered in the antenatal period will be applicable more strongly in postpartum period.
Yes.
Is it right?
Yes, so
So,
we would change iron replacement.
yeah, you have to look for the reasons for non-compliance and this dependence on the oral iron therapy after the delivery. It is WHO recommended, all right, but then in patients with non-compliance, I think we should take some other measures so that the iron supply is given in the postpartum period. So in cases where you need injectable iron therapy, I'm sure you have discussed all this. That thing is continued even after delivery in the form of top-up dosage or additional dosage. But reliance on oral therapy, I think, is not a very good option in these particular cases. Because once the baby is born, the entire priority or the attention of the family shifts towards the baby, not towards the mother. That's the unfortunate story of all pregnant mothers. So I think that you should take care of that. And these are all social issues you need to take care of. So while we say about uh, uh, advice, postpartum advice and counseling, you need to tell the family members properly the importance of having iron in the postpartum period, continued iron, and they should be more focused on that instead of just focusing on the baby. So that if you have slightest doubt about this compliance issue again, which I'm sure you'll have, then I think it is advisable to go for an injectable, another second dose of iron before discharging her.
Yes, yes, sir.
So I think Dr. Mukhopadhyay, nicely presented by students.
Yeah.
And good interaction. Actually, offline थोड़ा मुश्किल लगता है. Online में you have your patient also. And, I think we are also little conscious while asking because कुछ repetition हो जाता है. But this I would like to congratulate Dr. Maushmi for for her students encouraging them, and a lot of thanks to you. As far as your occipital posterior was, sir, it was very nice as it's your favorite topic. I know that also, as a common examiner in many exams. And one thing in that also, I would like to add on that sometimes no occipital posterior diagnosis becomes so easy. Just you walk into the labor room, and from the distance only, if you'll see the the lower abdominal flattening and that sigmoid sign, just you can make out and ask your residents the findings. And when you verify, you many a times something which is missed is this only.
Yeah.
So one common observation as a teacher, I would say that just for occipito-posterior, all the complexities and tricks are there. But I think in the diagnosis, if we are vigilant enough to see our patients very carefully, that is there. So with this, thank you so much, sir. Thank you, everyone. Thank you, dear students. All the best for your exams. I'm
Thank you,
sure you
ma'am.
will do well. Yeah,
Anemia
yeah,
in pregnancy is a very vast subject, and the
Very
cross
vast. Yes,
yeah,
yes.
can go in any direction. So I think students should be prepared, and that's why we in ICOG always try to repeat these common scenarios. We have
yeah.
discussed it before also, but there are many angles to handling a case discussion, and crossing can go any direction. And therefore, I
Yeah.
think students should learn from multiple opportunities of, like for instance, the labor also. Labor also we have discussed before. The anemia in pregnancy we have discussed before. Prolapse also we have discussed before. But time and again, repeatedly, if we go on harping them, I think something will be imprinted in their mind. And there are many angles to a case presentation or lecture or demonstration. Whatever way you look at it, the students should be aware of. All these are practical things. These are not available in textbooks. Like that question I like very much. That why does the head take the longer route, 3/8 of a circle, in spite of finding that it is a shorter route there? That question was very interesting. That means that is why where they become interested in the vaginal delivery issues. So I think that all in all, it's an attempt from ICOG, and I believe that students will grow a habit of going into the website and going through all these classes over the last 3 years. I think they will find a treasure there, if you for their oral practical examination. So thank you very much, our dear examiners, our dear candidates, Dr. Monica and Dr. Bithika, and
Thank you, sir.
and examiners Dr. Kavita Singh, Dr. Shakun Singh, and Dr. Jitesha. We have done a wonderful
Thank you.
Thank you, sir.
just
Thank you, sir.
glimpse of what can happen in a practical real life scenario in case. And I agree with Dr. Singh that yes, in offline it becomes slightly different. And there are a lot of
Yes,
other
sir.
factors, but you must agree that the adrenaline factor is much less here.
Yes, sir.
I have seen the students always looking at the ceiling or the floor because they don't want to look at the examiner. So, yeah, that problem is solved. Thank you very much, all these
Yeah.
examiners. Students, you have done exceptionally well, very good. And I must thank Dr. Maushmi Das Ghosh also. She has guided her students very well. Thank
Sir,
you so much.
thank you.
Thank you,
for the
sir, for
Sir,
Thank you.
Ashish,
Thank you.
Ashish, sir, thank you for the opportunity to Tata Main Hospital. Our students have done well under your guidance and encouragement.
No, it's my
And
pleasure.
Dr.
It's all your hard work and my pleasure.
Dr. Hafizur Rahman
Yeah.
and Dr. Ashok sir also.
Yeah.
So, and all the examiners, thank you so much.
Thank you.
Thank you,
Bye-bye.
sir,
Have a
for
nice,
Thank you.
nice Sunday,
Thank you,
everyone.
sir.
Thank you.
Okay.
Thank you. Bye-bye. Bye.
Thank you.
Bye.
So we come to the, kindly stop sharing. So we have come to the last part of our session, to the last session of today. That is our theme is master the technique. And the students are also required to develop some techniques, examination technique as per NMC guidelines. So we have done a case discussion. We have done a dummy fetus pelvis. Now we are going into the master the technique, that is how to examine a case of prolapse. And to do that, I think we have our faculty, Dr. Niharika Dhiman. She is a professor of OBGYN at Mohan Azad Medical College, New Delhi. Dr. Dhiman, are you ready with your presentation, madam?
Yeah,
Or-
good afternoon. Good afternoon, sir.
Good
Good
afternoon.
Yeah, I'm ready. I'm ready. Yeah, and so at the onset, I would like to thank ICOG and Ashish sir, Dr. Ashok, Dr. Hafizur for giving this opportunity, because per se getting a patient and then examining the patient for hours and hours and teaching is not possible. But here we could get 2-3 patients and we, kind of clubbed those findings so that we,
Consolidated, yes, yes,
yeah,
yes.
so that we could, actually give and set examples or difficulties which the PGs pose, because I really agree that prolapse must have been done a number of times, but I have come up with some points which the students get confused. And so I think I'll be able to highlight those points through the PPT as well as the videos incorporated into it.
Thank you, madam. The floor is yours. Kindly start the presentation if you have one, and share the screen. If you have a presentation,
Yeah, I have a presentation.
then share screen. Open the presentation and then share screen.
Yes, it's already open. So are you able to see it?
Yes, we can see. Just make it full screen.
Yeah. Yes.
And you are comfortably visible and audible. So you start.
Yes. Yeah, I'm starting right away. So greetings from Maulana Azad Medical College. And so, yeah. So I'll be quickly, basically the aim of this presentation is how to actually formulate a diagnosis. And I've been given the topic of actually demonstrating the examination of a pelvic organ prolapse. But before starting the exact or the precise examination, we should, be kind of focus on the specific points on general physical examination, which includes BMI of the patient. Your gait should always be mentioned whenever you do a general physical examination. Chest auscultation, per se cuff itself can predispose and even, can kind of damage your post-op repairs also. Stria is actually correlated with the, deficiency in the collagen or the connective tissue. So stria, if there are, please do document on the per abdomen finding. Ascites, other surgical scars per se also lead to development of prolapse. So please do document. And a neurological examination is must, where basically you see that I will not go into the detail that you can read it. You can basically, what you need to do is you need to go from L1 to S4, all the dermatomes should be assessed. And basically we are seeing the sensory and motor distribution of the pudendal nerve. So that has to be done in the neurological examination, as it may be a cause to the prolapse. Yeah. So basically, whenever we do a pelvic organ prolapse, the goal is you need to know the severity of the prolapse, the degree of pelvic floor support, the integrity of the connective tissue on the vagina. That is the main goal. So you should arrive to your diagnosis, and your diagnosis should meet all these goals. More so, your diagnosis should always means try to meet the history that you are putting along with the diagnosis, the points that are favoring your diagnosis. Okay, so basically the PPT or the demonstration will go on as follows. First, we'll talk about local examination, followed by palpation. Then we are going to do examination under two subheadings. One will be the site-specific examination. Per se, we all, whenever we operate on a prolapse, we say it has to be a site-specific repair. So we need to do a site-specific examination, followed by the most popular, and I think the part which confuses the students most is the POPQ examination or classification. Then pelvic floor muscle testing would also be included, and how to formulate a diagnosis. So yeah, so very important whenever you examine a patient in your exam also, sometimes you're not able to demonstrate the maximum prolapse. So you should always, try to examine the patient in a position where the maximum prolapse is demonstrable. Okay, and mostly it is achieved by either making the patient sit down, squatting, and then doing the Valsalva, or cuff reflex has to be done. So basically what we do, we have done examination in dorsal supine or lithotomy position, or maybe in squatting also. Examination, the points that have to be taken in account is the introitus, then you have to examine the cervix, the vagina, if there is any demonstrable SUI, stress urinary incontinence, the anal sphincter has to be seen here, and the perineal body and the reflexes. So I'll begin my video here. Please let me know if the video is playing or there's a problem. Can you see the video? Yeah. So firstly, we need to examine the external genitalia, okay, the labia majora, minora, and then separate both of them to see the hymen and the vestibule and the vagina. So here we are separating the two labial folds. We are seeing the hymenal ring, the remnant of hymenal ring. These are very important landmarks. Then we also see the urethra, press the urethra for any abnormal discharge. Then we see the perineal body. Here you can comment on it that the perineal body appears to be attenuated. More so, the perineal ring is deficit in the anterior part. The wrinkling of the skin is deficit in the anterior part. Now ask the patient to do a Valsalva maneuver or to cuff to see how much prolapse is actually coming out. And this has to be done with a full bladder so that you can also demonstrate SUI in this. So here we see that the cervix has come outside. So first we are going to visualize the cervix. Yes, cervix is outside the introitus or the hymen, that we can see. There is no erosion, ulceration. The cervix looks healthy. That has to be noted down whenever you do the local. Again, ask the patient to do Valsalva. You see the vagina. You see for the rhegostes, you see here the rhegostes are absent. There's a big bulge on the interior vaginal wall. Comment on the rhegostes. The rhegostes are absent here. We also focus on the sulci. I want to just verify, I'm to just enlighten here that there is submetal sulcus, the transverse sulcus, and there is a bladder sulcus here, where the bladder is ending. Very important landmarks, usually being asked in the exams to show where all these. Then we have the lateral recess, which lead to the lateral sulci. Again, a very important landmark to differentiate between central and lateral defect. Here again, the other sulci, the lateral sulci. So you should also comment on the sulci here, the vaginal rhegostes. How is the vagina? How is the rhegostes? Look for any ulceration or any keratinization. We did not find any ulceration or keratinization here in this patient. So we've covered all the points here, starting from the labia minora, majora, then demonstrating the SUI, then going on to the cervix, going on to the vagina, where vagina, you are seeing the rhegostes, the pattern, where they are absent, commenting on the sulci, any hyperkeratinization, any ulceration. Then the perineal body, which was attenuated in our case, and the anal sphincter. Sorry. Yeah. So after that, we also need to, if there is a big prolapse, we also need to palpate. Why we need to palpate? You will write down on palpation. The cervix was felt, you need to feel the cervix, but it also tells us how much cervical elongation is there if it is supra cervical elongation. And in case of prosidentia, the palpation all the more becomes more important, because here you can approximate your thumb and the index finger above the uterus, and that is suggestive of a prosidentia. And sometimes with massive cystoceles and big prolapse, you are even able to feel the ureters on the side and can be commented whenever you are doing a palpation. Yeah. So moving on to the site-specific examination. We've done the local examination, and now we are going to the site-specific examination of pelvic organ prolapse to see where the defect actually lies. In this, what you need to know is that the entire pelvic organ prolapse is divided into 3 compartments, which I'll be demonstrating in the video: the anterior compartment, the apical compartment, and the posterior compartment. So we'll be seeing it here. Yeah. So here we have just lubricated because it was quite dry, so we didn't want a trauma. So here we see, this is the anterior compartment, which I've just shown. This is the apical compartment, which includes the cervix. And then we have the posterior compartment. So it is very important to note, whenever you do a compartment-specific examination, what you need to do, whichever compartment you are visualizing or examining, the other 2 compartments have to be retracted. Here, while examining the anterior compartment, we have used a SIM speculum and retracted the cervix and the posterior vaginal wall downwards, so that we are only able to see the anterior compartment. And in the anterior compartment, we need to see whether there is a central defect or a lateral defect. So here you see, we're asking the patient to do a Valsalva. You see there is a big bulge in the center. The vagina is actually flat. There are no rhegostes. Again, look for the sulci. The sulci are maintained. Look for the UV fold here. The vesicle, the vesicle sulcus is also there. Now what we do, we see whether it is completely central or some lateral defect also. Slightly reduce the mass, use a ring forceps and introduce laterally along the lateral recesses as far as possible. Ask the patient to again do a Valsalva. We see the bulge is again being demonstrated in the center, which shows that it is a central defect. Now coming on to the apical, retract the anterior and the posterior vaginal wall with 2 speculums, or you can even use a SIM speculum. And we see there is a cervix which is coming down to the 3rd degree level. For the posterior defect, we have put in a SIMS as high as possible and ask the patient to cuff slightly, keep withdrawing your speculum. As you know, this was a bit tricky case because we had a high rectocele here. So you see the bulge, as we withdraw it down, we have a posterior vaginal wall defect here. So to sum up, we had a On the anterior compartment, we had a central defect, which was identified with where there was a central bulge. This is how you're going to even write it. There was a central bulge and rugosities were absent. And you also supported the ring test you did. You supported the lateral sulci. Still the defect was there. It signifies that there is a central defect. The repair has to happen there. And also the inference is that is majorly, it is a cystocele that is happening because of the deficient fascia in the vagina. And then we had a third degree UV central apical defect and a posterior wall defect, where it could be a high enterocele or a high rectocele or an enterocele, which is a little bit tricky diagnosis. So this is the defect specific examination. Sorry. Yeah. So whenever we are doing the posterior compartment defect enumeration, we always have to supplement it with a rectal examination. Basically, why rectal examination is important? Rectal examination is important to differentiate between rectocele and enterocele. Percy also tells us about any rectovaginal defects, differentiates it from rectal prolapse and pseudorectocele. That is why you are going to do a PVR examination. So in the first diagram, you can see we have put in a finger, index finger into the rectum and try to take it out anteriorly. If it goes into the defect, it is suggestive of a rectocele. Moreover, the Sims test, if the bulge is on the tip of the Sim, then it is an enterocele. If it is while withdrawing the Sims, the defect starts appearing, it is a rectocele. Another test which I couldn't get a picture and as was not very clear is you can do a 2-finger test where one finger goes into the rectum, the other goes into the vagina, and ask the patient to do a Valsalva. If you feel that there is a bulge between the finger, then it is most probably a rectocele. If at the tip you feel the bulge and you can feel some loops are there, then it is suggestive of enterocele. So these tests are important from exam point of view also. You will also be asked about these tests and how to differentiate between rectocele and enterocele. So you do a bimanual examination after that, where you need to comment on the uterus size. Mostly prolapse case, the uterus, whenever the uterus descends down, it becomes retroverted. Also comment on the adnexal. There should not be any adnexal mass. So after you have done the compartment specific defect examination and you have done a PVR, what you need to also do is to do the muscle testing. So muscle testing grading, in exam you will quote that yes, it has been graded according to the modified Oxford scale. So here's a video demonstrating how the levator muscle has to be tested. So for the levator muscle, you have to go laterally at 5 o'clock or 7 o'clock position, 3 to 4 centimeter inside the vagina. Now see here, my thumb is feeling the levator ani muscle. Okay, it is not just at the perineum, it is a little bit far away from the perineum. The belly, you are holding the belly. Ask the patient to hold the act of micturition or the act of urination. And then what you see is, you see whether you can feel, two things you need to see is, you need to see whether the muscle is actually contracting with your fingers and thumb, and the inner vaginal fingers, are they getting squeezed or they are getting lifted? So in our case, you see there was a flicker. I could feel that there was hardly any rise of the finger or squeezing. The introitus was quite gaped and the muscle tone was lost. So the tone of this patient was almost 1/5 according to a modified Oxford classification. So till now, what we have done is general physical examination. After that, you have done a site-specific examination. You have also done a PV and a PR for this patient, and you have also assessed the levator toe. So coming on to the second quantification, see, because why I'm talking about these two systems, because whenever you write your diagnosis, you need to know which compartment defect it is there. You need to quantify your prolapse, which will be by POPQ. And in the diagnosis, you also, sometimes as examiners, we would also, apart from POPQ, we also like you to mention Shaw's classification. Commonly, it's that how we expect our students to also mention one of the other classification. Okay. So now we'll be talking about POPQ classification. You all are well versed with all these tic-tac-toes and the traditional diagram which has been going on. So I'll highlight important points here. Always, why I talked about bladder sulcus there is, whenever the bladder sulcus is there, BA will always lie between AA and the cervix. So in case you need to check whether, my BA is actually correct. So the distal most AA ke baad, there will be the bladder sulcus. It will not go beyond the bladder sulcus and beyond AA. So just remember that it will always be between C and the bladder sulcus when you see there. Okay. So that is a gross mistake. If you go beyond the sulcus and you mark BA, that will go even beyond AA. So we all know that the anterior, just a minute, I'll take a pointer here. Yeah. Are you able to see the pointer? Okay. So AA, we all know there are fixed point, AA 3 centimeter proximal, then which corresponds to AP, and then these are the two mobile points, BA and BP, and then cervix is the superior, these are the anterior and the posterior compartment. The superior compartment forms the C and D. So important, C is the cervix. C could be any leading point. It could be either the anterior lip or the posterior lip. Remember this. Any part of the cervix which is leading, or which is the distal most, will be taken as the leading point. So it could be anterior lip or posterior lip. Why I mentioned posterior lip is here? Because please do not get confused with D as posterior lip. Another very important point coming up is identification of D. Here is where most of you get confused. So D refers to the posterior fornix. Posterior fornix, remember, it is the highest point on the posterior vaginal wall. And the other important thing, if you read always posterior fornix, you forget to read this line. It is always the point where the uterosacral are meeting the posterior cervix, posterior surface of the cervix. So it is very important to, actually palpate the uterosacrals, actually to feel for the uterosacral where they are meeting on the posterior the cervix on the posterior vaginal wall. That is the point of D. Okay. So don't get confused with how much of the vagina is in. Please identify it again by palpating the uterosacral in the posterior fornix. So that is how we identify D, and D signifies D is the part of the where the uterosacral meet and the pouch of Douglas starts. So another important point is, whenever you're examining the posterior wall, you're getting confused with D. One is, I told you, you look for the uterosacral, wherever the uterosacral is meeting, there will be the point D. And another important, hint is there. Another important hint is that you always see where you are going to open the posterior pouch. Wherever you're going to open the posterior pouch, it corresponds to D. Okay. Yeah. So we'll quickly go on to the video for POPQ. So yes. So here we have the same patient. We are examining her. We're doing a POPQ. Remember this. For all these classification examination, the bladder should always be empty. Okay, make the patient lie down in a comfortable position, and the prolapse should be demonstrated maximally. Okay, and the role of timing, subah karna hai, sham karna hai, some books have written that is not at all relevant. Using tenaculum or traction, to demonstrate the prolapse is also not advisable. It is going to give an overestimation of the findings. Yes. So the important landmark is the hymen, which corresponds to the point 0. Okay, in case, in menopausal females, sometimes, or when the prolapse is very big, sometimes you're not able to identify the hymenal ring. Then what you will take reference is the urethral meatus. Urethral meatus also falls onto the circle, which is completed by the hymenal ring. So in case, in a very old patient or with massive prolapse, you might not be able to identify the hymenal ring. So take urethral meatus as the 0 point. So here we identify the urethral meatus. Then here is the midpoint of the posterior hymenal ring. Then here is the midpoint of the anal canal, anal ring. Okay, so these are the important landmarks we need to know. So we are measuring the AA point here, which is 3 centimeters. Marking it, what we have used is, we have used an Ayer spatula, which has already been graduated, and we have used 2 Q-tips. So we have marked AA here, and we have marked without the prolapse coming out. It is more easier. You can do it either ways. Okay. Now ask the patient to do a Valsalva. Now you see the prolapse is coming out. You can use either gentian violet or methylene blue or betadine, whichever way you feel it is easy. So now you see, now we are going to measure AA. So this is AA. Okay, this is the bladder sulcus that I was talking. So BA will, be marked anywhere here, which has the most distal point. So this is BA, and that is the cervix. So now, as you've identified all the 3 structures in the midline, now you're going to take the measurements from the hymenal ring. Yeah. So here, sometimes the hymenal ring might not be visible. You might have to little bit give traction onto the other side to the prolapse go to the hymenal ring. So it was +2 here. Little bit inside we must have gone, yeah. And the BP is here. You can take the other Q-tip and just delineate it. It is +2, 0 se bahar hai, to +2. And cervix, again the hymenal ring is the reference point, 0. And yes, little bit traction. And you see it is almost the anterior lip is leading here. It is almost coming to +2 here. So that is with the Valsalva. We have measured the defects. Now coming on to the posterior, I've told you I've got another pictures also, because here, you know, there was hardly any prolapse or high rectocele. But remember, mark the AP here in the posterior wall, 3 centimeters again. That is the fixed point. Okay. And after that, you can ask the patient to do a Valsalva here. And whenever the prolapse is there, you might not be able to see the posterior wall. What you need to do is you need to lift up the prolapse, and then you can take the subsequent measurements. Okay. Now, what here I'm doing is an important point, because, you know, we didn't see the posterior wall. There was hardly any defect in any descent at AP or BP. They were equal, corresponding to each other. But however, there was a descent or a prolapse at the posterior vaginal wall at a D. So what we have done, it couldn't be seen here. I am trying to palpate the uterosacrals. So wherever I have found that the uterosacral is getting attached to the at the posterior fornix, till there I'm going to put it and take the measurement. Okay, and the measurement here is +4. Okay, so that is how we have taken the D point. Okay, it might not always come out. So that is the D point here. So to complete the tic-tac, we have another measurements. Again, after, remember this, I've gone through a number of presentations, and even for RPGs, what mistake they do, there is only one measurement which is taken with the prolapse inside, that is TVL. All the other measurements, including perineal body and genital hiatus, has to be measured with maximum straining with the prolapse out. Okay, that has to be remembered. So now we are measuring the genital hiatus from the mid-urethral point till the midpoint of the posterior hymenal ring, and see the patient is straining maximally. In case there is a huge bulge, you can even use 2 Q-tip at the urethral meatus and the midpoint, and then you can take the distance between them. So that is +6 here. Okay, now we are going to measure the perineal body. Again, ask the patient to strain from the mid-hymenal point. You can see the hymenal ring, and the mid-anal point. We are going to, yes, this is the mid-anal point, and it is again 2, it is attenuated. So and we've pushed back the prolapse, deposited in, then we are taking the total vaginal length, which is +7 here. Okay. So we have completed our grid here. So we see there was, and there is more of anterior defect here, and leading point is C, cervix, as well as the cystocele part or the anterior vaginal prolapse, +2. And important is TVL. You have to see what is the limit of the TVL, because this will help us in staging. So see, AP and BP were still there. That is why we said D is -4, though it should be somewhere around 7, or maybe depending upon the TVL. So D is still inside, but definitely coming on towards the hymen. So that actually signifies there might be an enterocele or might be a high rectocele, which has to be, you know, it is a little bit difficult to know. So that is when the cervix is there, we make this grid. And I've already told you only TVL to be measured when with the prolapse inside. So that is the POPQ quantification. So yeah, because, you know, I thought because you were not able to see point AP. So this is another case where, you know, now there is posterior vaginal wall defect and prolapse is there. So what we have done here is we have already marked the AP point. It has come down to somewhere around +4, +5. And this is how we are measuring BP here. BP has also come down to +3 here. And for D, remember this. See now, what we are doing is, some students are, you know, measuring D here. This is not D. See, this is AP here. AP के आगे नहीं D आ सकते. AP cannot be beyond D. It has to be towards the cervix. Okay. So what we are trying to feel here is we are feeling the uterosacral. So D is somewhere here. Okay. And then you mark D here, and then you take the actual distance from the hymen. Okay, so remember, don't do this to come beyond AP towards the introitus. Okay, that will be a mistake. Okay, so go towards the cervix to see D and feel for the uterosacral, like thumb and index finger are feeling the uterosacral. So yes, after that we need to stage it. You all know the staging. For our patient, leading point was more than +1, but less than TVL -2. TVL -2 was 7 - 2, which was 5. So our leading point was +2. So it was, how do we write it? We write it stage 3 pelvic organ prolapse with multi-compartment, because it has both anterior and apical, or the superior compartment, and the posterior compartment defect. And leading point was C. C is the one which will have the most positive values in the anterior and posterior wall, will be your leading point. There was without any stress urinary incontinence with a levator tone of 1/5. And in case there is any ulceration or keratinization or any other abnormal finding you are seeing, then you are going to mention it in the diagnosis itself. So another classification, why you should always have two, classifications written whenever you write a diagnosis. Examiner would, like it. Yes, you know the other one also. And so for the other classification, our case would be a 3rd degree V descent, uterovaginal descent with cystocele, a high rectocele. There is no enterocele, no erythrocele, and no stress urinary incontinence. That is how I have removed the grading of cystocele, rectocele per se, because they are not used anymore now. Basically, cystocele has been always divided into central or lateral defect. Okay, it can be central or lateral or apical if it is including the erythrocele. So you can avoid writing that. Yeah. So just the class would be incomplete if I don't talk about these two reflexes, which tell you about the intactness of the pudendal nerve, the bulbocavernous reflex, where what you do, you stroke the lateral wall of the clitoris and you see the side, the one which has been pointed out here, the bulbocavernous muscle is going to contract on both sides. That is the bulbocavernous reflex. Inner wing reflex is on stroking the anus. What you do, you elicit the contraction of the anus. Okay, the anal canal contracts, and that shows the intactness spinal cord, pudendal nerve also. These are the neurological examination which should be mentioned whenever you do the local examination. It should be mentioned there and then. Yeah. And a word about stress urinary incontinence, very important. That patient has to be examined full bladder. Full bladder, yeah. So you separate the labia, ask the patient to do a Valsalva maneuver or cuff, then it can be demonstrated there. Wherever there is a massive cystocele, you have to also demonstrate occult stress urinary incontinence, which is what you need to do is you need to deposit the mass back and again demonstrate stress urinary incontinence when there is a big cystocele. Okay, if there is a stress urinary incontinence, you see there is a urinary leak on increasing the abdominal pressure, you need to do a Boney's test. Here we have depicted the Boney's test. Your two fingers, the index and the lateral finger, will go parallel to the urethra. Okay, what this test does is it supports the mid-urethra. It supports the mid-urethra. So do not obliterate the urethra per se. Otherwise, your test will be false. So you need to support the mid-urethra. So you need to go actually 2 to 3 centimeters beyond the urethral meatus. And then again, ask the patient to cuff. If it is positive, then definitely that means the uretrovesical junction has been altered. Then there is also the Q-tip test where you see the angle, inserting a Q-tip for, basically this is for the hypermobility. And it is just, I think for theoretical point of view, it is important. You should know this test also. Yeah. A word about vault prolapse. Important things a PG should note. Again, you're going to do a site-specific repair, site-specific examination and a POPQ in this. So important points here of difference and of clinical relevance is whenever you get a case of vault prolapse, first thing you have to see is the dimpling. The dimpling or the scarring is the area which marks the cuff and which marks the C point. Every relationship or a relation of other anterior and posterior walls is with the C point. So cuff becomes the C where you see the two dimples where the old uterosacrals were attached. Accordingly, we are going to grade or make a tic-tac. If it is anteriorly, then you are going to accordingly mark AA and BA, okay? And posteriorly here, because we know the posterior fornix in the uterosacrals are not there. So, and the cervix is not there, that is placed by cuff. So D point is not there. You don't need to mention a D point here. And accordingly, you are going to stage the vault prolapse. So that would be my last slide. And thank you all. And these are two very important references for your reading purpose, where you can actually read the entire examination, the order in which the examination has to be presented. Both of these have a complete documents in themselves. Yeah. Thank you so much. That's all from my side.
Thank you, Dr. Niharika. It was a very elaborate and excellent presentation and demonstration of how the students should examine and record a case of pelvic organ prolapse. And I think there are many variations in examinations. I know some people, they always mention that the examination should be in the squatting position or standing position or dorsal position. The most important idea is to get the maximum part of the prolapse outside. That means for examination. So quantification basically demands that you should be able to visualize the maximum part of the prolapse, individual compartment by compartment, and that's what you have demonstrated. But the students should also remember that there are alternate positions that the examiner might insist on, and in that case, it is just for the sake of convenience of the patient also and comfort of the patient also. That also has to be taken into consideration. But what you demonstrated is an excellent way of showing the maximum degree of prolapse in all compartments and how to grade them, how to quantify them. I think students have got a clear message. There was some confusion or question about the posterior compartment, I believe. In the chat box, if you open the chat box, you will see there's a question was that, ma'am, please repeat posterior compartment measurement. I mean,
Yeah,
yeah.
I'll share the slide again, or they want me to just.
I think they just focus on the posterior compartment slide and then.
Yes.
And there was also another question on transverse sulci. Actually, I think you made it very clear, the transverse sulci. If you could show the.
I'll show it again, sir. Because sulcus, usually students, we ask them this question, they are mostly, they give us some looks then. Nahi ma'am, ye to nahi aa raha. I'll show it here. Let me see. Yeah, so see, there are these sulci. Yeah, wait.
Yeah, I think the sulci are visible.
Yeah, see, this is the bladder sulcus here. Okay, and here, is the, yeah, this is the submeatal sulcus. This is the transverse sulcus, and this is the bladder sulcus. Here down. Actually, my finger is kind of obstructing it. The vesical sulcus.
I think it is easily conceivable about the junction, anatomical junction of the.
These are the lateral recesses where you have the lateral sulci, which is far beyond this. It goes deep, as you know, they are the ligaments. So these are the lateral recesses or the point of lateral sulci here.
The sulci are nothing but the anatomical junction points between the urethra and the bladder, and also bladder and the cervix. So I think they're easily visible there. Yeah. Could you go back to this thing, posterior compartment, and yes.
Yeah. I think I'll be able to show this. Yeah.
Yeah.
So we had a video of this also. If I can play that video, the posterior.
Yeah.
Okay, I'll just see what you do here is we have actually, you go inside and you, with this prolapse gone inside, you mark AP first, okay, which is +3, -3. From the hiatus, you go -3, you point AP, you mark it, and then you ask the patient to do the Valsalva, and you see where actually that marked point AP is coming. It is just similar to how we have done it in the anterior wall, okay? So there, where it comes out, it is the distance from the hymen of the, I would say, of the fixed AP point is taken, is the calibration for AP. Okay. And for BP is again the most dependent portion between D and the AP. So the most leading point. So this was, see, this marking is here is the AP here, and this one is the most leading point here. So this
It's 2 o'clock.
have actually kind of calculated here. So this is where AP is, this is where BP is falling. Yeah. And for D, what I was saying, please do not get confused. यहाँ पे cervix है. After cervix, you feel for the uterosacral, and D will be somewhere here. And then you measure it from the hymenal ring. You measure D. How much is it coming outside? Okay. So any confusion?
Yeah, actually, seeing on a patient is different than
Yeah,
seeing
exactly.
on a screen. I believe that the posterior lip can be lifted up. Then you can, if you could show them the point AP and then the point BP. BP,
Yes,
during BP, you need to take out the speculum, of course. But while taking the AP, you can show that after lifting the posterior. So that is
Here
possible.
I think this is one video we have. See, now you lift up, no? And
Yeah.
this is the AP here. Actually, it was a problem loading it, so I couldn't put it on. So see, you lift it up, and then you see here, there is a marking, AP, and then you see where AP is and ask the patient to do Valsalva. I think they can appreciate it here.
Is the video running? We can't see the video running. Are you running the video now?
Yes, sir. I'm running the video.
So it's not visible. Kindly rerun the video. Just press click on the arrow.
So just a minute. I'll just stop sharing and share again.
Yeah.
Are you able to see it now, sir?
Now it is visible. Yes.
Is it playing?
It's playing now. It's playing.
Yeah.
Yes.
So see here we have already marked. Again, I'll go. Here we have already marked the AP here. Okay. So AP is there and we are trying to trace the hymenal ring. Now, as I said, we have lifted the cervix and here is the AP. Okay. Now from the hymenal ring, why you need to lift up and see the hymenal ring and then ask the patient to do a Valsalva. You see AP has come out. That mark has come out. So here we measure and simultaneously we are also measuring BP here. Okay. So both things have been measured. Again, we are repeating the same thing. AP
is the most leading point, so that will be easier for the students to understand.
Leading point, yes. BP and BA are the most leading points, okay, that you have to find between CNAA and D and AP. Okay, this is the hymenal ring, and here is where we are demonstrating the uterosacrals. We are palpating the uterosacral to see D. So D will be somewhere here. Actually, the video has been cut short till here. So D was here, and then it came down to somewhere here till 4. Okay, so it will not be here. So I think, sir, would that.
I hope that the students are clear about these concepts now. And thank you very much, Niharika. It was an excellent demonstration. And it was good to see that such painstaking demonstration of all the points. And it all depends on practice also. And I think the students would do good if they study in a few live cases and see for themselves. Any confusion, they can ask their teachers.
And I would actually acknowledge the efforts taken by my residents, Dr. Preeti and Dr. Rachita, who helped me make these videos, and my patient also, who was so cooperative.
So sweet of them, yes. So I think that it's 2 o'clock now, and we have come to the end of our today's all the sessions. So with plenty of thanks to all the faculty members, I think it's my pleasure to wind up this today's session, because all good things have to come to an end. And Professor Niharika, thank you once again for an excellent demonstration. I believe that it has been very useful for the students. Dr. Ashok Kumar, are you there?
Yes, sir. Today it was, I suppose, one of the best program today we had. We have a very good presentation by you, then a very good discussion by all the examiner and the students. Students were also excellent. They have discussed it very well, and in the end, you say, Niharika has done wonders, and whatever we expected, she has fulfilled those points, and this is our demand from her, that she should show the pelvic organ prolapse demonstration examination in a very easy way, and she has done that very beautifully. Thank you, Niharika, and
thank you so much, sir.
I
That
think,
means
sir,
a lot to me, sir.
Yes, And now we will inform the student that these all recordings will be available on the ICOG website
Right.
by tomorrow. And these are the things which can be reviewed and revisited every time. And again, I am thankful to all our teachers, experts, and Foxy ICOG also.
Correct.
Thank you, sir. We can wind up now with the closing remarks. Thank you very much.
Recording may be off now.